Welcome to EPG Pathshala on the subject Social Medicine and Community Health. I am Professor Vidya-mitra working in the Department of Community Medicine, Institute of Medical Sciences, Banaras Hindu University, Varanasi. I shall be discussing the module National Health Policy 2002 and beyond. This module belongs to the paper National Health Policies and Programs. The module has been developed by a team comprising of myself as Principal Investigator, Dr. D.K. Taneja, Professor and Director, Department of Community Medicine, Maulana Medical College, New Delhi, as Paper Coordinator, Dr. Ranbir Paul from Department of Community Medicine and Family Medicine, AIIMS Jodhpur, as Content Writer, and the content has been reviewed by Dr. Bratati Banerjee, Professor, Department of Community Medicine, Maulana Medical College, New Delhi. The learning objectives that has been set for this module are: number one, after going through this session, one should be able to understand the scenario in India after implementation of National Health Policy 1983, need for a new health policy, that is National Health Policy 2002, after the enactment of the first policy, the National Health Policy 1983, and objectives of National Health Policy 2002, goals of National Health Policy 2002, and draft National Health Policy 2015 that was done as a follow-up action after the implementation of National Health Policy 2002. Now, whenever one as a health planner or as a program organizer, one need to understand what is policy. Policy is a statement of intentions. It means that what government intend to do for the people of a particular country. Following National Health Policy 1983, attempts were made to restructure and reorganize the healthcare in terms of provision of, number one, at least one trained birth attendant and one health guide at village level per 1,000 population. In this process, National Health Policy gave a political will so that rural health scheme following Srivastava Committee report also got momentum. The idea was that there should be a person who should interface with the health system and the community at large. The outreach part, where a particular paid staff of the government public health system remains a sub-center. So, trained birth attendant and health guide, they become interface between the community at large and health system, the peripheral part. The second important thing was one sub-center for 5,000 population in plain areas and 3,000 tribal, hilly and difficult areas. One primary health center for 30,000 population in plain area and 20,000 population in tribal and difficult areas, with 4 to 6 beds manned by medical officer. One community health center CSC for 1 lakh to 120,000 population in plain areas and 80,000 in tribal area and difficult areas, with 30 beds. Provision of a specialist and specialists are posted at community health center. It was emphasized that once we have a network of sub-centers, primary health center, community health centers, there should be efficient referral mechanism. Unfortunately, referral mechanism in India has been very weak, and it was emphasized following the National Health Policy 1983 that we should develop a system of two referrals, and once referral system is established in a systematic manner, it will be pay dividends. Specialty and super specialty services are to be strengthened, to be established, Even in that process, FRI, that is, first referral units, were created to care, prioritize action for mother and children, so that maternal mortality and child mortality can be brought to a particular level. So, following the implementation of National Health Policy in 1983, there will be structural corrections in the health system, and India has developed a huge infrastructure in terms of a network of primary health centers, sub-centers, community health centers, and strengthening of secondary and tertiary hospitals. Since the evolution of National Health Policy in 1983, there has been significant changes in the determinant factors related to health sectors, necessitating revision of the policy. A number of things were achieved following National Health Policy in 1983, but there were some great transitions. Transitions in terms of ecological transition, in terms of demographic transition, in terms of nutrition transition. So, on the one hand, we were not able to resolve the issue of communicable disease. On the other hand, there was a significant rise in the non-communicable diseases and also behavioral diseases, necessitating for revision of policy. Country's health system continues to face, it was realized that following implementation of the system of rural health system in terms of CSCs, PSCs and sub-centers, still there were many challenges. Against this backdrop, particularly challenges in form of functionality component need to be addressed, and therefore against this drop it was felt that it would be appropriate to pitch or to bring out a new policy, and in the terms of National Health Policy 2002 with the realistic expectations. The changed circumstances relating to health since 1983 had also generated a situation which mandate to review the field and to formulate a new policy framework as the National Health Policy 2002. Although in between we had National Population Policy 2000, but National Population Policy was primarily directed for the welfare of the masses in terms of accelerating demographic trends in the country, and with the aim to population replacement, reaching to displacement fertility by 2010 and population stabilization by 2045. National Health Policy 2002 recommends to maximize the broad-based availability of health services to the citizens of this country on the basis of realistic considerations of the capacity. National Health Policy 2002 attempted to set out a new policy framework for accelerated achievement of public health goals in socio-economic circumstances then prevailing in the country. So, a number of policy prescriptions were made in the National Health Policy 2002 with the idea that whatever existing socio-economic circumstances prevailing in that country was accelerated to the extent that the public health goals are optimized are achieved to the maximum. The policy was focused on those diseases which are principally contributing to disease burden, that is tuberculosis, malaria and blindness from the category of historical diseases, HIV, AIDS from the category of newly emerging diseases, and also it emphasized on other environmental basic determinants of health like environment, nutrition, and also the emerging trend of non-communicable diseases. A number of objectives have been set for in the National Health Policy 2002. Number one, the policy aimed at achieving an acceptable standard of good health of Indian population. The policy clearly said that we should not emphasize only on survival issues, we should not emphasize only on mortality issues, we should try for achieving an acceptable standard of good health of Indian population. Policy also emphasized on decentralizing public health system by upgrading infrastructure in existing situations. Capacity building at peripheral institutions was our public health system at every level of care, with strengthening referral mechanisms. Ensuring a more equitable access to health service across the social and geographical expanse of India. Although infrastructure in terms of sub-centers, primary health center, community center have been created, but their functionality was a big challenge across social and geographical expanse of India, and therefore policy clearly said that in those areas where system is not working optimally, more emphasis should be given so that equitable access of health services becomes available, particularly in the vulnerable sections of the society. The National Health Policy 2002 also emphasized on providing health service for people who can afford to pay, but giving primarily for those people who are below poverty line, who have less ability for payment, so that catastrophic expenditure, they should not fall into that. Policy also emphasized on giving primacy for prevention and first-line curative initiatives. The emphasis was more on prevention and first-line curative initiatives. Expanding rational use of drugs. Prescription audits have clearly shown that whether it is the private sector or it is the public sector, there is irrational practice of prescriptions are going on, and many of the drugs which are not needed, they are being used. So enough emphasis was given on rational use of drugs. In order to ensure that WHO and many countries in the world have prepared list for different drugs which can be considered at different level of care. And also the drugs were classified into three categories: vital drugs, essential drugs, desirable drugs. And an optimum mix was tried so that there should not be irrational use of drugs. The policy also emphasized on increasing access to tried systems of traditional medicine like Ayurveda, Unani, Siddha, homeopathy, and so on. Now, if you look, the major objectives of the NHP was reflected clearly when we launched National Rural Health Mission. The National Rural Health Mission had various components. The most important component was the reproductive and child health. The second most important component was the provision of National Disease Control Program, both communicable and non-communicable. However, HIV and AIDS were kept in a separate program. Then the third component was, which our National Rural Health Mission aimed at, is provision of or addressing the issues related to basic determinants of health, that is environment and human nutrition. From the operational angle point of view, ASHA was, that is accredited social health activist, was brought into the picture, and Ayush, that is Indian system of Ayush means Ayurveda, Unani, Siddha and homeopathy, attempt was made to streamline them into the system. So traditional medicine was brought into focus. As far as goals of the National Health Policy 2002 is concerned, there were a number of goals have been set in. The goals to be achieved by 2005 reflected to eradication of polio and ARS, elimination of leprosy, increase state sector spending from 0.5% to 7% of the budget. Goals to be achieved by 2007, achieving zero level of growth for HIV and AIDS, establishment of an integrated system of surveillance, national health accounts and health statistics, because it was realized that mere release of funds is not going to work, or only allocation of funds will not make a difference. We have to have an accountability, and we have to have a system of monitoring and good governance in the country so that health can progress in it. Goals to be achieved by 2010: elimination of Kala-Azar, reduction of mortality by 50% on account of tuberculosis, malaria, and other vector-borne diseases, particularly Japanese encephalitis, AES, and dengue, and so on. Reduce prevalence of blindness in the country to 0.05%. Reduction of infant mortality rate to less than 30 per thousand and maternal mortality to 100 per lakh 2010. At the country level, we have not reached to this level till date. Increase utilization of public health facilities from current level of less than 20% to more than 75% by 2010. And increase health expenditure by the government as percentage of gross domestic product from the existing 0.9% to 2% by 2010. Increase share of central grants to constitute at least 25% of the total health spending by 2010. Further increase of state sector spending from 7% to 8% by 2010. So, a number of goals have been set in. These goals were achievable. For that purpose, policy prescriptions were made, and it was realized that once these policy prescriptions are implemented in the realistic sense, they will make a difference. In fact, National Health Policy 2002 had been a continuum of the National Health Policy 1983, emphasizing on that primary health care has to remain as the main strategy even in National Health Policy 2002 as it was during the period following in the implementation of National Health Policy 1983. Emphasis was on decentralization, on equity, on involvement of private sector in the system of participation, and rise in public investment. India has made considerable progress in the public health since independence. Eradication of smallpox, poliomyelitis, Guinea war, MERS, elimination of leprosy and neonatal tetanus in the country. We are very close to elimination of leprosy. The strategies of NRHM, National Rural Health Mission, though resulted significant improvements in the key health indicators in terms of institutional deliveries, full immunization, and availability of diagnostic and family welfare services in many states of the country, but still there is a room for further accelerating the activities. After the enactment of National Health Policy 2002, NRHM was launched in the country, and significant achievements were obtained in some of the areas. But the challenges in provision of healthcare were rising in the country because NCD was emerging, non-communicable disease was emerging major threat in the country. And majority of the deaths in the country were occurring because of non-communicable diseases. It was also realized that urban areas are more vulnerable. There are certain pockets in the urban areas known as urban slums. Their health indicators are poorer than even the rural areas. So it was realized that something has to be done for urban areas as well. And along with the National Rural Health Mission, Urban Health Mission came into being. Just before the start of the 12th five-year plan, Government of India initiated many high-level committees, and these committees came out of the recommendation that there is a need for another national health policy, emphasizing on the fact that around 2% of the India's population below poverty line every year goes below poverty line just because of catastrophic expenditure of health. And the health insurance system particularly is so weak that not more than 1 out of 10 get the benefit from health insurance scheme. So in order to cut down catastrophic expenditure on health care, we have to act differently. And therefore, the high-level committee came out of the recommendation that there really should be universal health access. In universalization of health care, in that attempt, it was a draft National Health Policy 2015 was created. And this draft National Health Policy kept a goal that stands as the attainment of the highest possible level of good health and well-being through a preventive and promotive health care, orientation in all developmental policies, and universal access to good quality health care services without anyone having to face financial hardship as a consequence. So, the draft National Health Policy talked of very pertinent, relevant issues that were being faced by the people of India. It came out with certain concrete recommendations. One, primary care services and continuity of care to provide comprehensive set of preventive, promotive, curative and regulatory services on a continuum basis from home to tomb. So that's the one, adopting life cycle approach and so on. The secondary and tertiary care services, a concept of strategic purchasing, which refers to the government acting as a single payer, purchasing care from public hospitals and private providers as a part of a strategic plan of district health development systems. Infrastructural development, normative approaches in their development to targeted approaches to reach underserved serviced areas. A conscious effort shall be made to identify districts and blocks which have the larger gap for development of infrastructure and deployment of additional human resources. So prioritization issues came into front in terms of infrastructural development. A functionality element was brought into that, and reaching the unreached in provision and emphasis on universal health care. When we talk of universal health care, it becomes very pertinent to discuss that what constitutes universal health care. It was since health costs money, provision of health costs money. So a set of entitlements has to be decided for depending on the capacity to pay, and so unless we many other initiatives have been taken in provision of universal health care. Human resource for health has been identified that in a particular facility, be it sub-center, be it primary health center, be it community health center, what are the human resources that for health that should be. So this group has recommended the measures have been proposed to enhance the training, retaining, placement, incentives of doctors and other human resource for health that is required for this. A number of suggestions have been also given to provide affordable, quality health care. Health care through the public health system as its main form of social protection government initiative. For uniformity in public and private health care, it is compulsory for all levels of health care to get accreditation from the National Accreditation Board for Hospitals and Healthcare Providers, so NABH. For quality assurance, it is necessary that both public and private healthcare facilities be accredited by the National Accreditation Body. Also, we have to take into cognizance that Indian public health standards are there for rural areas. In urban areas, we are going to develop primary health centers, sub-centers, community health centers, and so on in the future. So, simply expanding facilities will not make a difference unless logistic support, unless quality and credentials and credibility of the public health systems are improved. Holistic multi-sectoral approach is desired because medical departments can provide curative care. Health is a subject that requires integration of various sectors, be it agriculture, water supply, rural development, economic development, and so on. Education per se makes a lot of difference. Holistic approach should be adopted to address public health challenges. Universal health coverage should extend to elderly population, those with communicable disease and non-communicable diseases both. Impact of climate change should also be considered because many climatic manipulations, climatic control is desired. Otherwise, this changing spectrum of disease spectrum will make a lot of challenge for provision of universal health care in the country at large. Focus on health volunteerism. Traditional healers, they have taken care of the health needs of their own community as a part of their social responsibility. India has a rich heritage of traditional healers. But however, these traditional healers can be streamlined in the provision of the health, not only curative care, but other types of preventive and promotive actions. They use the knowledge that has passed down to the generation from generations regarding the medical value of locally available herbs and plants. Ayurveda has a big role to play. What is needed that there should be standardization. This tradition will continue, particularly in the tribal pockets of the community. Voluntary organizations have an immense potential in simplifying the complex process of health policy. It adopts a one-solution-suits-all approach by decisively pursuing an insurance-based healthcare model for facilitating a near monopoly of the corporate sector in curative care. Even under corporate social responsibility, that activity has to be harnessed in a particular way so that the maximum benefit can be obtained for the community. Much has been made for harnessing private health care for achieving public health goals. However, the fundamental contradiction between the objectives of private and public health sector is too powerful to be undone by theoretical formulations. That requires very strict public-private partnership. It is easy to say, but there should be clear-cut agreement then what kind of services will be taken care by private sector, and also it should not be go in a blanket way where public sector is weak, where private sectors can strengthen the public system. That type of approach should be followed. But what is more important is the quality assurance from the public-private sector in provision of healthcare is desired. Complex national and international forces have been at work in shaping the present idea of universal health coverage through a much more holistic approach of primary health care. However, universal provision of health care requires huge financial outlays, and therefore the question of minimum entitlements comes into, depending on the capacity to pay, and that in that way endeavors should be made, so that should be decided, that should be implemented. Finally, you must say that National Health Policy 2002 has energized, geared up the activities of public health sector following the implementation of National Health Policy 1983. In National Health Policy 1983, primary health care was considered as the major tool, and Health for All 2080 targets were designed. National Health Policy talked of an amalgamation of a system which will take care of the national priority, that rural national reproductive and child health. It will also has emphasized on integration of communicable and non-communicable diseases, national disease control programs, both in the area of communicable and non-communicable diseases, and it has also addressed the main strategy regarding to addressing the basic determinants of health, like total sterility campaign and human nutrition. ICDS, Integrated Child Development Scheme, which was going through, that has been initialized in the country, and major focus has been given on that. The main strategy that National Health Policy 2002 has taken, that primary health care will remain the potential tool for implementation of the health program in India. It has emphasized on decentralization, it has emphasized on equity issues, it has emphasized on involvement of private sector in business system participation, ensuring quality control, and also it has emphasized on more resource allocation or more funding for public sector. Because unless the spending part is taken care of, particularly if you look at Bangladesh and Sri Lanka, neighboring states or countries, although their per capita income is not much better than India, but since their proportion of health spending of GDP on health sector is more, they are getting more dividends. National Health Policy 2002, following that, a lot of changes had taken place. An NHM was launched, Urban Health Mission was launched, National Health Mission came into force, and before the implementation of the next plan, it was realized many high-level committees were set in. These committees came out with very concrete recommendations for universal health access, and also taking care of that catastrophic expenditure on health care should be cut down so that people should not come below poverty line just because of that catastrophic expenditure on health care. The health of any nation is the sum total of the health of its citizens, communities, and settlements in which they live. What is important here? That what proportion of people have been reached is not important. What is important that what proportion of people are left out of the ambient of provision of health care. It is always understandable that those people who are not brought into the ambit of health care, they must be more vulnerable, their health conditions must be poorer, they must be victim of poverty and so on. And therefore prioritizing those areas and also involving those sectors like non-governmental organizations, like private sector, which can work in those areas. And also many industries, many organizations are coming up. They have a corporate social responsibility. Their money should be judiciously used in those areas which are more vulnerable, where services are not reaching to the optimally. A healthy nation is therefore only feasible if there is a total participation of citizens towards this goal. So community participation, multi-sectoral linkages in healthcare is desired. In India, in the last 5 decades, we have followed a path of social transformation that mainly relies on 5 major institutions, namely the parliament, the assembly, the cabinet, the bureaucracy, and party functionaries. What is important? There should be a strong political will, but there should be a mechanism which will implement whatever is they brought into the policy. Because simply policy, as I said earlier, is only the statement of intentions. But simply intentions will not be able to take care of the health of the people of a country. That requires a mechanism, that requires a system, that requires a systems-based approach has to be taken into care so that we can take care of this. Thank you very much for visiting EPG Pathshala.